I am going to say something today that goes against everything most people have been taught about medical care, and I want you to hear it carefully because the nuance matters enormously. More testing is not always better medicine. For a 45-year-old, routine screening tests are largely beneficial. The diseases they detect are at stages where treatment meaningfully extends life. The procedures required are well tolerated, and the risk of harm from testing is low. The mathematics of screening at this age generally favor the patient. After 70, those mathematics change. Not for every test, not for every patient, but for 5 specific routine tests that are recommended and performed in adults over 70 with remarkable regularity. The evidence that the test does more harm than good in this age group is both substantial and consistently underrepresented in the conversations that happen between older patients and their physicians. My name is Dr. Robbins. I have spent 20 years practicing internal medicine with a focus on the care of adults over 65. And in those 3 decades, I have seen what happens when the medical system applies screening protocols designed for 50-year-olds to 75-year-old bodies without adequate adjustment for what is different. I have seen patients come in healthy and independent and leave a cascade of tests and procedures that cost them their independence. Not maliciously, not negligently, because the healthcare system runs on protocols, and the protocols do not always stop to ask whether this specific patient, at this specific age, with this specific health profile, will benefit from this specific test. I want to be completely clear before we go further. Nothing in this video applies to patients with symptoms. If you have chest pain, rectal bleeding, a new neurological event, a breast lump, or any other active symptom, investigate promptly and thoroughly. That is not what today's video is about. Today's video is about the routine, symptom-free, scheduled screening that happens to adults over 70 simply because it is on a protocol, and the specific tests where that protocol, applied without individualization, causes more harm than it prevents. And I want to say one more thing up front. You have the right to decline a medical test. You have the right to ask whether it is appropriate for your age. You have the right to understand what happens next if it is positive. That right is not exercised enough, and I hope today's video gives you the framework to exercise it. Here is the conceptual foundation for everything I am going to say today. It has 3 components, and once you understand them, the arguments for each of the 5 tests will make immediate, logical sense. The overdiagnosis problem. Many conditions that screening detects in adults over 70 are what clinicians call indolent. They are present. They are technically diagnosable. But they grow so slowly and so quietly that they would never cause the patient any harm in their remaining lifetime. The problem is that once detected, the healthcare system's momentum moves toward treatment. Treatment of an indolent condition that would never have caused harm produces only the side effects of treatment, with none of the benefit. This is overdiagnosis. And in adults over 70, it is extraordinarily common across multiple screening categories. The aging body handles the consequences of positive screening tests differently from the younger body. Bowel prep dehydrates an 80-year-old far more dangerously than a 50-year-old. The contrast dye used in cardiac catheterization stresses 75-year-old kidneys more severely than 50-year-old kidneys. Surgery in an 80-year-old carries a fundamentally different risk profile from surgery in a 60-year-old. The test itself may be the same procedure, but the body receiving it is different. And the protocols that schedule these tests rarely account for this difference adequately. This is the mechanism that most patients never anticipate. A routine test produces an abnormal result. That result requires follow-up. The follow-up test produces another finding. A specialist is involved. A procedure is recommended. A complication occurs. And the patient who walked into the screening appointment feeling well and independent is now managing a complication from a cascade that began with a test for a condition they did not have, or had but would never have been harmed by. I call this the cascade trap, and understanding it is the single most important conceptual shift in how adults over 70 should think about accepting routine medical testing. Now let us go through the 5 tests. Test number 1, routine colonoscopy after 75. The U.S. Preventive Services Task Force explicitly states that screening colonoscopy in adults aged 76 to 85 should be an individualized decision based on patient health status, and that there is no net benefit from screening adults over 85. These are not fringe positions. They are established guideline recommendations from the most authoritative preventive medicine body in the United States. The reason is simple biology. Even if a colonoscopy in a 78-year-old finds a small polyp, a common finding, the time required for that polyp to develop into a clinically significant cancer is typically 10 to 15 years. In a 78-year-old, that timeline extends well beyond the realistic benefit window of detection. Finding and removing that polyp does not extend the person's life. It creates a patient category with follow-up schedules, repeat colonoscopies, and the anxiety of surveillance for a condition that was never going to cause harm. Bowel preparation for colonoscopy produces a rapid and significant fluid and electrolyte shift. In a healthy young adult, this is a manageable discomfort. In a 78-year-old with heart failure, kidney disease, or on multiple medications, conditions that describe the majority of adults in this age group, the bowel prep can be medically dangerous. Hospitalization following colonoscopy preparation in older adults is well documented. The preparation for the test causes the harm, not even the procedure itself. Perforation during colonoscopy, rare, but real, requires emergency surgery in an 80-year-old body that is far less resilient to that operation than a 50-year-old body. The mortality associated with colonoscopic perforation repair escalates dramatically with age. I had a patient, 82 years old, sharp and independent, whose son drove her to a routine colonoscopy scheduled by her GP. During the bowel prep the evening before, she became confused, fell in the bathroom, and fractured her wrist. The colonoscopy was canceled. She spent 3 weeks in recovery. The colonoscopy she was preparing for had been her first in 12 years, and the decision to schedule it at 82 had been automatic rather than deliberate. Nobody had asked whether the benefit of finding anything justified the risk of preparing for the procedure. What to ask instead: request stool-based testing, the fecal immunochemical test, as an alternative. It requires no preparation, no sedation, no procedure, and no cascade risk. Test number 2, aggressive breast and prostate screening 30, the overdiagnosis problem in sharp focus. I want to spend a moment on the word overdiagnosis because it is the most important concept in understanding why aggressive cancer screening after 70 so frequently causes harm without benefit. Overdiagnosis means finding a cancer that would never have caused the patient any harm and then treating it with interventions that do cause harm. It is not a conspiracy theory. It is a well-documented epidemiological phenomenon with extensive published evidence, acknowledged by major cancer organizations including the American Cancer Society and the National Cancer Institute. In prostate cancer, the concept of the Gleason score was developed specifically to distinguish aggressive cancers from indolent ones, but even with this tool, the cultural momentum of a positive PSA test and a positive biopsy pushes powerfully toward treatment. And in men over 70, the treatment side effects, permanent incontinence, permanent erectile dysfunction, cardiovascular effects of hormone therapy, can be devastating to quality of life in ways that a slow-growing prostate cancer that was never going to kill the man was not. The USPSTF recommends against routine PSA screening in men 70 and older for precisely this reason. The harm evidence is consistent and substantial. In breast cancer screening, ductal carcinoma in situ (CIS) is a condition frequently detected by mammography in older women that the research increasingly shows is often overtreated. Many CIS lesions would never progress to invasive cancer in the patient's remaining lifetime, but their detection triggers biopsies, surgery, radiation, and hormonal therapy, all of which carry significant risk and quality of life impact in an 80-year-old body. A 74-year-old woman I cared for had a routine mammogram that identified CIS. Surgery was recommended and performed. Post-operative complications required a second procedure. She developed a wound infection that required 6 weeks of antibiotics. By the time she recovered, she had spent 4 months as a patient, missing her granddaughter's graduation, unable to drive, dependent on family members for basic activities. Her pathology was low-grade CIS, with a virtually zero probability of having progressed to invasive cancer in the remainder of her lifetime. The treatment took more from her than the disease ever would have. What to ask instead? Have an explicit conversation with your physician about what you would do if a test is positive. If the honest answer is that aggressive treatment is not something you would choose given your age and health, the question of whether to screen at all deserves serious discussion. Test number 3, routine cardiac stress testing. The false positive rate of cardiac stress testing in low-risk, asymptomatic older adults is not a minor inconvenience. In some studies, it approaches 40%, meaning that in a group of asymptomatic older adults who undergo routine stress testing, approximately 4 out of every 10 positive results represent a normal heart that the test has incorrectly flagged as abnormal. Now consider what follows a positive stress test. Virtually invariably, the next step is a cardiac catheterization, an invasive procedure carried out under local anesthesia and sedation in which a catheter is threaded through an artery in the wrist or groin into the coronary circulation. In older adults, this procedure carries risks of bleeding, contrast kidney injury, stroke, and arrhythmia that are measurably higher than in younger patients. And if catheterization finds a blockage, even one that is hemodynamically stable and producing no symptoms, the clinical pressure to place a coronary stent is substantial. The Orbita trial, a landmark randomized trial, found that coronary stenting in patients with stable angina produced no improvement in symptoms or exercise capacity compared to a sham procedure. For asymptomatic patients, the evidence for stent benefit is even weaker. The cascade from a false positive routine stress test, catheterization, stent, antiplatelet medication, GI bleeding from antiplatelet medication is a series of real risks in service of an initial false signal. A 75-year-old retired engineer, excellent exercise tolerance, no cardiac symptoms, had a stress test at his annual wellness visit. It was abnormal. He was referred for catheterization. A 70% blockage in a secondary coronary artery was found. A stent was placed. He was prescribed aspirin and clopidogrel, dual antiplatelet therapy. 3 weeks later, he was admitted with a significant upper GI bleed. He required endoscopy, blood transfusion, and a week in hospital. The stent that caused this was placed in an artery that was not causing him any symptoms and would likely have remained manageable with medication alone. What to ask instead? Cardiac investigation when symptoms develop. Not routine scheduled testing in asymptomatic adults over 70. Test number 4, routine bone density DEXA scans with medication follow-up. I want to be specific here because the concern is not with bone density measurement itself. It is with the medication that typically follows in older adults who are found to have low bone density. Bisphosphonate medications, the standard treatment for osteoporosis, reduce vertebral fracture risk in the age groups where they have been studied. But in women over 80, for whom the trial data is sparse and the benefit less clearly established, they carry 2 uncommon but significant risks. Atypical femoral fractures, paradoxical fractures caused by the oversuppression of normal bone remodeling by long-term bisphosphonate use, can occur with minimal or no trauma simply while walking. These fractures require surgery and have a slow and difficult recovery in older adults. Osteonecrosis of the jaw, the death of jawbone tissue typically triggered by dental procedures in patients on bisphosphonates, produces a painful, chronic, difficult-to-treat wound in the jaw. In an older adult already dealing with dental problems, which are extremely common in this age group, the addition of bisphosphonate jaw risk from a medication prescribed for a DEXA finding is a significant quality of life concern. The more fundamental issue is that after 75, falls are responsible for the overwhelming majority of hip and wrist fractures, not bone density alone. A woman with normal bone density who falls on her hip will fracture it. A woman with osteoporosis who never falls will not. The most effective intervention for fracture prevention in adults over 75 is fall prevention, not medication for the bone density number on a DEXA report. A patient of mine, 79 years old, on bisphosphonates for 5 years following a DEXA scan, developed thigh pain that was initially attributed to arthritis. X-ray eventually revealed the classic appearance of an atypical femoral stress fracture, the bisphosphonate complication. She had never fallen. She had never had a traumatic fracture. The medication prescribed to prevent fractures had produced one. What to ask instead? Balance training, strength training, medication review for fall risk contributors, vitamin D status assessment. These are the evidence-supported fracture prevention interventions after 75. Test number 5, routine carotid artery ultrasound in asymptomatic adults. The USPSTF recommends against routine carotid artery screening in the general adult population, including adults over 70, on the basis that the benefit of identifying and surgically treating asymptomatic carotid stenosis does not clearly outweigh the risk of the surgery itself. Here is the specific paradox. Carotid endarterectomy, the surgery performed for significant carotid stenosis, carries a perioperative risk of stroke and death of approximately 2 to 3% in most published series. In older adults with more fragile vasculature, higher comorbidity burden, and reduced physiological reserve, this risk sits at the higher end of the range. The very patients for whom the surgery is intended to prevent stroke are the patients most at risk from the surgery causing one. For asymptomatic carotid stenosis found on a routine scan in someone who has had no symptoms, the annual stroke risk without surgery is approximately 1 to 2% in medically managed patients. The surgical risk of a stroke or death from endarterectomy is 2 to 3% in the perioperative period alone. The mathematics of this comparison, particularly in older adults, do not favor routine surgical intervention. And when the scan is negative, when no significant stenosis is found, it provides no information that changes medical management because optimal medical therapy, statins, blood pressure control, antiplatelet medication, is appropriate regardless of what the scan shows. A 64-year-old man, no neurological symptoms, no TA history, had a carotid ultrasound as part of a private health screening package. An 80% stenosis was identified in his left carotid artery. He was referred for endarterectomy. During the procedure, an embolic fragment was dislodged. He woke from surgery with a right-sided weakness. He spent 4 months in rehabilitation. He had walked into the screening center with no symptoms of stroke and walked out of rehabilitation with a permanent deficit from a surgery performed to prevent that outcome. What to ask instead? If you have symptoms, TA, transient vision loss, speech difficulty, investigate immediately. If you have no symptoms, optimal medical therapy is the evidence-supported management, and a routine screening scan is unlikely to change that management while adding the risk of a cascade toward surgery. Before you agree to any routine test after 70, ask these 4 questions. Question 1, what will we do differently if this test is positive versus negative? If the management is the same regardless of the result, if the answer is medical therapy either way, the test adds risk without adding benefit. Question 2, what is the false positive rate, and what does the cascade look like from there? Understand the entire pathway before the first step. False positives in low-risk older adults are common. The cascade from a false positive can be more harmful than the disease being screened for. Question 3, is this test guideline supported for my specific age group? Many screening guidelines have age-based upper limits. Ask specifically whether your age group is included in the evidence base for the test being recommended. Question 4, what is the realistic benefit time frame, and does it match my life expectancy? If the benefit of detecting a condition accrues over 10 years, and the realistic benefit horizon for a 78-year-old in average health is 5 to 7 years, the test may not produce the outcome it is designed to produce within the relevant time frame. I want to say this as clearly as I possibly can. If you have symptoms, any of the symptoms I described throughout this video, please seek medical evaluation promptly. Chest pain, rectal bleeding, neurological symptoms, a breast lump, bone pain. These require investigation, and nothing I have said today suggests otherwise. The 5 tests I have described are specifically concerning when applied to people who feel well, who have no symptoms, and who are being screened by protocol rather than by specific clinical indication. The presence of symptoms changes the calculus entirely. This video is not anti-medicine. It is pro-informed medicine, the kind of medicine in which patients understand what is being done to them, why, and what the risks are. That kind of medicine produces better outcomes than any protocol ever written. After 30 years of internal medicine, after 30 years of watching cascades unfold, watching patients lose independence to complications of tests for conditions that would never have harmed them, watching quality of life diminish in service of a number on a scan report, I have arrived at one conviction that I carry into every patient encounter. The goal of medicine after 70 is not to find the most things. It is to preserve the most life, not just in years, but in quality, in independence, in the ability to do the things that make life worth living. Routine testing that produces cascades of harm in the service of detecting conditions that would never have caused harm is not good medicine, even when it is performed by excellent physicians following standard protocols. It is medicine that has not been adequately adjusted for the specific reality of the aging body. You have the right to ask the 4 questions. You have the right to decline a test that does not make sense for your age and your circumstances. You have the right to say, I would like to understand the evidence for this specific test in people my age before I agree to it. Exercise that right. For yourself. For the people you love. Leave a comment telling me which of the 5 tests resonates most with your experience or your family's experience. I want to hear from you. And your story may be the thing that prompts someone else to ask the question they've been afraid to ask. Please hit like if this was valuable. Share it with someone over 70 or with an adult child who is navigating healthcare decisions alongside a parent. Subscribe for weekly content on informed healthcare after 70, evidence-based, patient-centered, and honest about what the research actually shows. Your health after 70 is too important to leave on autopilot. Take the wheel.